Hello, everyone, and welcome to Frontiers in Substance Use Care, Emerging Topics and Evidence, an immersive podcast series sponsored by the Providers Clinical Support System, Medications for Opioid Use Disorder. I'm Keena Thakrar, an addiction medicine and infectious disease physician and longtime member of the MRSA community. For those new to the podcast, MRSA is a national organization dedicated to bringing together disciplines and perspectives to strengthen substance use care through collaboration, evidence-based practice, education, and advocacy. This series explores the evolving landscape of substance use and addiction care. In each episode, we highlight emerging research, new clinical challenges, and innovative care models shaping the future of the field. If today's conversation sparks ideas for your own practice, we invite you to explore additional education opportunities and resources available through MRSA at imrsa.org. And now, let's turn to today's episode. For patients with cancer and substance use disorders, managing pain safely and effectively presents unique, yet often difficult challenges. Opioids remain the standard of care for cancer-related pain, yet clinicians must also consider risks such as recurrence of use, overdose, and fragmented care. How can providers balance effective pain treatment with recovery goals? And how can addiction, oncology, and palliative care teams work together to support these patients? In today's episode, we explore practical frameworks for managing cancer-related pain in patients with substance use disorders, including strategies for interdisciplinary collaboration, opioid stewardship, and coordinated care that supports both cancer treatment and recovery. Joining us today is our host, Dr. Katrina Nichols, a palliative care and addiction medicine physician at the University of Kentucky, whose work focuses on improving care at the intersection of pain management and addiction. She is joined by Dr. Justin Colgren, a clinical pharmacist specialist in pain and palliative care at the Ohio State University Wexner Medical Center, whose work advances interdisciplinary approaches to opioid stewardship, and Dr. Lauren Kelly, an addiction, geriatrics, and palliative care physician at Mount Sinai, whose work focuses on improving care for seriously ill patients with substance use disorders. The presenters report nothing to disclose. Thank you for joining us. Let's begin.
Thank you, Keena, and welcome everyone. Thanks for joining us. I'm your host, MRSA member Katrina Nichols, and today's episode focuses on cancer pain and addiction recovery. And we're joined today by Lauren Kelly and Justin Colgren, two incredible expert guests with experience in addiction medicine, pain and palliative care, cancer pain management, and interprofessional collaborations. And we're so glad you're here. Hi, Lauren.
Hey, thanks for having me.
And Justin.
Yeah, thanks for letting me be here.
Okay, great to have you. So we're going to talk about cancer pain and addiction. And to help frame our conversation, I'm going to start by sharing 3 learning objectives. And these are the key themes we hope listeners take away. So first, opioid agonist treatment with buprenorphine or methadone for opioid use disorder is important and challenging to continue in the context of cancer pain management. Number 2, we need to adapt the patient education conversation surrounding the use of opioids to balance both pain and the need for rational opioid use with the context of stigma of addiction. And then third, cancer trajectories are complicated because of advances in oncology, so everyone needs to be skilled in survivorship care and caring for patients with chronic pain after cancer treatment. Okay, so let's jump in. Before we dive into, how do we manage patients with cancer pain and addiction, let's step back, and if you could explain for the audience, why is this such an important topic right now?
Yeah, so cancer survival improvements mean that there are a lot more people surviving and living with cancer. Over 18 million people in the US right now. And more people living with cancer pain who require opioid medications. There are also high rates of substance use disorder in the population of patients with cancer, somewhere around 5 to 10%, depending on the literature that you're looking at. And it's also different depending on the type of cancer. So, for example, we see rates over 10% in the head and neck and esophageal and gastric cancer populations, where substance exposures are very directly linked to the development of that cancer. And there's also a lot of stigma that we have to combat that makes it challenging for patients with substance use disorder to get access to good pain care. So, and a lot of misunderstanding on the part of clinicians about what the best practices are and what makes us liable when we're treating patients with both pain and substance use disorder. But treating cancer pain and substance use disorder is the right thing to do. It's supported by guidelines, like the most recent CDC guidelines, which calls for individualizing pain treatment. And it's also supported by consensus studies in the cancer patient population. But we know that patients who have substance use disorder can have a really hard time getting pain medications when they need them. And, I think it's important to recognize that appropriate prescribing of controlled medications is legally protected. For example, in New York State, we have an article that outlines legitimate use for opioids in patients with substance use. So we shouldn't fear liability. And in fact, withholding pain treatment can be considered in violation of the Americans with Disabilities Act. The reality is that we can do this safely, and we need to provide the education and the exposure to clinicians that they need in order to improve their confidence in managing patients that have cancer pain and substance use disorder.
Yeah. So what I'm hearing from you is, for people with substance use disorders and they have a lot of cancer, they also have a lot of pain. And so, treatment of both is appropriate. And for anyone who's worried about prescribing opioids for cancer pain, that is protected. But, my understanding, working in palliative care and around oncology and in cancer pain, that historically, cancer pain was kind of treated differently than the other pain conditions, right, with the CDC guidelines. So how does that kind of lend to why cancer pain in particular and, addiction is unique as opposed to other patients with pain and addiction?
Yeah, Katrina, that's a good question. So, I think when you strictly think about opioids and pain management, there's been this kind of divide between cancer pain management and non-cancer pain management. And prior to 2016 guidelines by the CDC, we didn't have really a gold standard kind of guideline to lend to, but practice patterns always differentiated those two patients populations. And for whatever reason, patients with cancer just have received this kind of like hall pass where you have cancer, you have pain, and you kind of get opioids. And so, in many ways, there was kind of less. I don't want to say less, but maybe folks kind of viewed them a little bit differently. And so there was, I mean, not as much detailed evaluation in terms of those patients and the risk they may have for other concerns about use of opioids. So I think just that kind of changed with the CDC guidelines. So the CDC guidelines not specifically, well, they did specifically actually exclude patients with cancer from there, but those guidelines did begin to slowly trickle down and begin to have this peripheral kind of effect and damage to cancer patients because we saw all these changes with state guidelines, state rules, as well as insurances begin to really restrict opioids. And even though cancer patients were excluded from that, we did see some of the downstream effects of decreasing access for cancer patients needing opioids, and particularly for patients with substance use disorder.
Yeah, there's just so much emotion around opioids, so much fear, right, for clinicians. And so, that's been a challenge. Like, on one hand, people are afraid to prescribe, as Lauren was describing, and then we risk undertreatment of pain. And on the other hand, maybe in the cancer population, this was the last group of patients who were affected by opioids, but definitely are impacted by it. And then especially for patients with addiction. What about for the patients, being in the middle of this? You've got, patients with addiction, as Lauren said, who are diagnosed with cancer, have pain, and then might being started on opioids, or just everybody who is aware about this concern. How do you think all this history that you talked about impacts them, and how should we approach that?
Yeah, absolutely. It's a bit of a sort of gymnastics trying to explain for new starts, I think, especially for starting patients newly on opioid therapy. And really for all patients who are new to opioids and for patients who maybe have been using opioids, I really try to frame the discussion around the medical use of opioids in severe cancer related pain. I say this is some of the most intense pain you can have. This is organ pain or destructive bony pain or severe refractory neuropathy. And some patients are really, really reluctant to start because they worry about developing addiction, or maybe they know someone or had someone in their family. And, I talk a lot about how serious opioid safety is to me and to our practice, and that we really closely monitor patients and we set goals, we set functional goals, and we try to anticipate opioid tapers if and when opioids are no longer needed. Really important, I think, to do that, to set that expectation prior to kind of getting on the train, so to speak. And I think relationship building is also key to getting that trust going for patients newly starting opioids for cancer pain who may be worried. I try to explain what the differences are between things like tolerance and dependence and addiction. So we know that tolerance and dependence are normal and expected in patients who are taking opioids regularly. It just means that the body is acclimating to using opioids and can experience withdrawal if the meds are abruptly stopped. And this is not the same as addiction, which is a pattern of compulsive use of a substance. So I really try to make that clear for patients. And, some people on chronic opioids do develop opioid use disorder. It's under 10%, so while it's not insignificant, it's not something that should interrupt standard pain care. And, we do also know that there's factors that increase risk. So having a personal or family history of a substance use disorder, having a mental health diagnosis, so we can increase monitoring in those patients. And I highlight the safety principles that I use in management for all patients, like checking in frequently, doing intake and periodic urine toxicology screening, doing pill counts, checking, the prescription drug monitoring program, prescribing naloxone, and measures like these.
You mentioned a couple, I think, key words we're going to say throughout, our time together today, and that was, I think, trust, collaboration. I think were two that stuck out to me. Time, and I say that because as we think about how we are a point of contact for our patients as they go through this cancer journey, and they have so many fears, not just about the cancer itself. You're right, but treatment of their symptoms and can I use this safely? And I think we work so hard to collaborate not only with the patient, but we take time to collaborate with our oncology colleagues because I think they themselves, if you had them in a room by themselves, would tell you that there's a level of concern or fear on their end as well, and they may not verbalize it, but I think we recognize that to be true. And then we also take time to reach out to our addiction medicine colleagues, and I think that's another way to build that trust with our patients, right? And this point of contact are also, I think, areas that help us increase our confidence to prescribe opioids, right? Because we've got these points of contact with ourselves, our teams, our cancer medicine teams, our addiction medicine teams, and then taking time to collaborate with each of them at least helps increase my confidence that we can use opioids safely with our patients.
So it sounds like the big key, I love how you explained it, Lauren. You're very like explicit as to what is happening in their body and why opioids indicated. Like you were talking about like destruction and bones, and like you're very clear on that. And then describing that there will be an exit plan with the tapering, and then so that they don't feel like they're being bounced around and having to prove themselves, knowing that all the other, healthcare team members are being, or that you're collaborating with them. And so that everyone's on the same page, knows that this is appropriate, that there's some monitoring and things in place.
I'll just add, Katrina, some patients do end up on long-term opioid therapy for their cancer pain, and that's okay. There's situations where we are, having to use these medications long term. I think talking about it actually makes people comfortable to hear that, there may be a time when they're not depending on these medications. For some folks, that can be reassuring. But in other cases, I have to say things like, well, here we are, and the pain is well managed, and we're actually not in a situation where we can come down on the medications because of how well they seem to be working for you. So there's different ways to have the conversation.
That's a great point. That's a great point that you're saying there's not just one way that this is going to go of like going up and going down. It's going up and reassess, but we can move. If you have that concern, we can move to going down. Again, going to that individualized approach. So yeah, thanks for sharing that. And so that's for, you guys talked about the patients who are maybe worried about starting opioids, right? And maybe aren't using opioids either prescribed or unregulated. Do you approach it any differently for patients who, are currently using substances or unregulated opioids?
Yeah, I can jump in on this one. I think, it's important to acknowledge a couple things like tolerance for opioids in someone who has an opioid use disorder is going to be much higher, and that there may be a degree of dysregulation in the way that they process pain as a result of being exposed long term to opioids. So I think kind of acknowledging those things up front and then thinking about some of the key principles that are supported by guidelines. Specifically, I'm thinking about ASAM's 2020 guidance. There's a section there, I believe it's part 9 on patients with pain. That's a nice, succinct summary. But the key principles are that we first need to fill opioid receptors to treat opioid use disorder before a patient's pain can be brought under control. In other words, patients with opioid use disorder should be offered medications for opioid use disorder, including methadone and buprenorphine, as the backbone of their treatment to suppress cravings and withdrawal. And then the medications for opioid use disorder can be divided in daily doses, so anywhere from 2 to 4 times a day to optimize the pain benefits. And then additional opioids can be used as needed on top of that, depending on the clinical scenario. And I think, even beyond the technical aspects of how we manage the medications, I think it's also super important to keep in mind that we need to recognize the stigma that these patients have faced. And, I really try to take the opportunity when I meet someone to align with them and make sure that they know that I know that they have pain and that this is something that we're taking seriously. And really, I just can't like overstate how important that moment of recognition is in an encounter with someone. That being said, like any other patient, we, want to emphasize the use of the lowest effective dose for the shortest duration. Again, that dose may be a little higher for someone who's opioid tolerant. And, for any patient with an active substance use disorder, I'm doing closer monitoring. So sometimes we'll do shorter fills, like 1 to 2 weeks, more frequent follow up, wraparound support from the interdisciplinary team. Like Justin said, we collaborate with addiction care providers or we refer them to addiction care if they're not yet connected to that. So these are some of the things I have in mind when caring for someone with a substance use disorder who has cancer pain.
Yeah, I really do like that thought of, we try to support these patients more, or especially early on as we are caring for them. So we might see them as frequently as every week if we're able to. I think that an important point for me to remember as I'm caring for these folks is sometimes an appointment burden, though we think it as a good touch point, sometimes can be challenging if they're going through active cancer treatment. It can be tough for these folks to come see us as much as we would like to, especially if they're receiving radiation on a regular basis along with their chemotherapy. But it also goes to the point of how we treat their pain. I think we all appreciate the use of adjuvant medications. It's surprisingly hard to use things like acetaminophen and NSAIDs in these folks, right? They can be wonderful medications to be supportive to their underlying opioids, whether it's buprenorphine or methadone. But recognizing with many chemotherapies, if they are kind of ablative chemotherapies, right, these folks are going to be very high risk for things like fever and infections. So our oncology colleagues might not like us using things like acetaminophen or NSAIDs, or might be high risk for bleeds because of those same things. So recognizing that sometimes, though we like to use these agents, they're really hard to use in the midst of their active cancer treatment, but important for us to recognize as we get through that treatment window and we revisit those patients. So I agree completely when I go that the opioids they're part of our treatment plan. They're there, and we want to maximize other agents, but it can be harder than we think sometimes, just given, again, recognizing some of the risks that come with their cancer treatments and side effects we're going to have from those.
Thanks for speaking specifically, right, for patients going through cancer treatment. In other settings, like when we were just talking about like acute pain in the ER, for example, right, Justin, you mentioned it. They always said like maximize NSAIDs, acetaminophen, but that's also what makes the treatment of somebody going through cancer treatment unique, and why that doesn't apply. Without getting too far into the weeds of all the different dosing, but having primary care clinicians listening to this, can you talk a little bit more about when you say using buprenorphine as to fill up the opioid deficit, right? To fill up the opioid receptors and to be treatment for opioid use disorder. I guess let's start with buprenorphine. What do you think people really need to understand when you're talking about opioid tolerance and all the different buprenorphine products and how that fits with cancer pain management?
Yeah, that's a really good question. So, we've learned so much over the last 10 years on how we think about utilizing buprenorphine for both opioid disorders as well as pain. There's a lot of good studies by Greenwald et al. that kind of show, right, the bupe dose and what level of opioid receptors are bound by buprenorphine. And I think we recognize that there's a certain threshold we really need to think about meeting in order to decrease the patient's overall risk for having a potential opioid or an overdose perspective, to help decreasing risk of desiring other opioids. So, if you think about 16 milligrams kind of being like the typical threshold, maybe 20, 24 milligrams a day in the treatment of fentanyl
And you're
era.
talking like sublingual, right?
Sublingual, yes. Thank you
Yeah.
for the clarification. Yes, sublingual buprenorphine. We recognize, depending upon what study you look at, you're looking at anywhere from 95% of receptors being occupied. Again, if you're looking at that 16 to 24 milligrams sublingual a day dose range. And we know that dose is quite beneficial in treatment of opioid use disorder. So we have I think, just a growing recognition of thinking about, again, the doses of 16 and 24 milligrams is kind of what we think about. Again, that's associated with roughly 95% of opioid receptors being occupied. And so that's really important for us to be mindful of that. That it's going to be impactful as we think about treating our patients. We do recognize that those doses are associated with pain reduction properties. And I don't know if 8 or 10 years ago we were quite confident in that statement. I think we know buprenorphine was a really effective pain medication, but at these higher sublingual doses, I think we weren't certain just how much bang we were getting for our buck, right? And I think we recognize now that buprenorphine is a very strong pain medication. I think it's almost a bit of a misnomer when we classify it as a partial mu agonist. I think what we've recognized over the years is that partial mu agonism, if you look back at the original data, is quite controversial when you look at an efficacy perspective. Efficaciously, I think we can see for most traditional doses it's equally effective for most opioids for pain. Thankfully, the partial agonism really comes into safety profile, which is why we like it in the treatment of obese disorder, right? We have a strong opioid binder that also has a very, very forgiving safety profile. It's a very safe medication. Within the pain world, the cancer pain world, we've come to have a growing appreciation for buprenorphine and how it can treat pain. And we use it widely within our palliative care institution here at Ohio State. So, again, to summarize, even at high doses, we recognize there is benefits for pain. The pharmacological profile needs to be thought of a little differently, though, because the analgesic properties don't last as long as those that we think about for opioid disorder. So we need to break that daily dose up, like Lauren was mentioned earlier. And then being mindful of using opioids on top of that. Our understanding has improved. We recognize that even at those higher doses, 16, 20 milligrams a day, there are still sufficient opioid receptors available for our short-acting full agonist opioids to bind. We ultimately don't know what that number is, but clinical practice has definitely taught us that even at 16, 20 milligrams a day, maybe even a little higher, we know that addition of short-acting opioids like morphine, hydromorphone, and others can have a place to bind and work, which we use to our advantage in our patients.
Yeah. So it sounds like the older thought that you had to be off of buprenorphine because you won't get pain, it working for the pain, that we're realizing that no, that's actually not the case. And you don't need to lower their doses. And could you also, when we talk about buprenorphine, because I've seen this in the palliative care realm, of just using buprenorphine, any product, but what do people who are not addiction specialists need to understand about buprenorphine?
Good point. Yeah, I come across this actually quite frequently. The dose matters, right? We recognize those products that are FDA approved for pain, the Butrans patch, the buccal film, this one that goes on the inside of the cheek. Those are FDA approved for pain. And at those dosage forms, they are not going to achieve high enough concentrations in the body to be even thought of for use of opioid use disorder, right? So from that perspective, though, they're wonderful pain medications. And some of our colleagues may think, oh, this really gives me, a good opportunity to think about this in our patients who either have current or, a recent historical diagnosis of substance use disorder. Though that's a good thought, you're not going to convey the benefit that you're hoping for in those lower dose products, just because, again, you're not going to get kind of concentration. So if we're really thinking about trying to manage both pain as well as opioid disorder, then we have to be thinking about higher dose sublingual buprenorphine products. I'd be interested from you, Katrina, and Lauren as well, both, like, what are those doses you think really do start to confer a benefit? Because they're right. Because I mean, we see some of that controversy there.
Yeah, I think it varies depending on the patient, and pointing out that patients who have opioid use disorder in the fentanyl era, yeah, we're looking at least 16 most of the time, often 24, very often 32 these days, milligrams of sublingual buprenorphine a day. I think in my experience, and there's also long-acting injectable forms that many of our patients come to us on, and we use full agonist as needed medications on top of those injectables. Yeah, I think there's no sweet spot. There's no specific sweet spot for a patient, but folks on long-term opioid therapy who do not have opioid use disorder, I'm finding are needing less sublingual buprenorphine to get at their pain, sometimes 2 BID or 2 TID or 4, TID. So it's and it really it's a range there. And I think for folks with opioid use disorder, they're needing those higher doses to really suppress craving and reduce withdrawal symptoms. And then, we kind of just go based on how the patient responds. If we're giving them, if they're on 24 or 32 and we're giving them PRNs and we're going up and up and up on the PRN dose and we're not seeing good relief, that's when we're maybe adjusting the buprenorphine, bringing it down a little bit, or, actually thinking about a conversion of the buprenorphine to methadone to get, more analgesic effect. So I think there's different scenarios there. How about you, Katrina?
Yeah, I would agree. The big thing is having the right opioid related diagnosis, right? Do they have the DSM-5 criteria of an opioid use disorder? And definitely, if it's fentanyl use disorder, it's the sublingual or subcutaneous long-acting injectable products, right? Just to get enough of that concentration so that you have enough opioid receptors saturated and happy. That's how I say it to the patients. Let's keep those receptors happy, they're full. And so for that patient population. But for somebody who maybe has been in long-term abstinence-based recovery of their opioid use disorder, we'll just say, well, we'll closely monitor how quickly, in cancer pain management, we quickly get to some kind of base long-acting opioid as a base with your PRN as needed, short-acting or immediate release opioid for that breakthrough pain that is very particular to cancer, right? So for them, we'll talk about, early on, I'm going to think about one of these buprenorphine products And maybe it is the lower dose because right now you don't show those signs, but I'm not going to be surprised if we get back to sublingual very quickly. And then also recognizing for the non-addiction specialist, a substance use disorder does not always mean opioid use disorder, right? Like we are talking about alcohol use disorder, stimulants. So just because somebody's using drugs doesn't mean that they're opioid tolerant and they're going to do that with opioids. But, alcohol being a sedative, again, for that safety profile, thinking about buprenorphine products. And then I use, actually, like just in your paper, about, some level of oral morphine equivalents, like where's the range that they might fall on when I'm thinking about the transdermal or buccal formulation. But yeah, that's been my experience of making clear. If we didn't get the opioid diagnosis correctly, then maybe I've missed the boat. If I missed an opioid use disorder with somebody who needs high dose sublingual, and then maybe I've gave them too much and they don't feel good because I used a sublingual product when I was still in the lower dose range for the others. And then those are the complexities of buprenorphine. And now if you guys could just speak to the methadone, when somebody's thinking about that, what kinds of challenges might come up with methadone, of how we have to rethink that when it comes to opioid use disorder and cancer pain? Is it much different from how we think about buprenorphine?
Certainly, there are a lot more hoops to jump through for patients who are taking methadone. Methadone maintenance involves fairly frequent for most patients visits to opioid treatment programs. They get a designated amount of take-home supply for the methadone. Dose changes can be hard to enact. Split dosing is rather challenging for analgesic benefit. At most, I've been successful with splitting the dose in half twice daily. 3 times a day to give somebody 3 bottles of methadone per day. And let's say they have a 28-day take home. There are very few clinics that are willing to provide that volume of take home supply. So we definitely run into a lot of logistics, and it's sometimes also just hard to get somebody on the phone at an opioid treatment program. So if I'm seeing a patient and they're on methadone maintenance, but they're starting head and neck treatment, chemoradiation therapy for head and neck cancer, I'm getting on the phone, I'm speaking to their provider, I'm saying, look, this patient is about to embark on this, what I anticipate is going to be a painful mucositis experience, and dividing their dose may be really helpful for this. Can we work together? Can I contact you as I continue to follow this patient on a weekly basis? I'm going to be starting them on oxycodone or morphine or whatever it is, and just so that they're aware that the urine toxicologies may look different and why that is the case. And so, yeah, we have to work a lot more closely with opioid treatment providers.
And it sounds like you're recommending that the patient doesn't just get this prescribed by their oncologist or primary care doctor or palliative care doctor for methadone treatment for opioid use disorder.
Yeah, absolutely. I mean, right now in this country, the way that this works is that methadone is dispensed in opioid treatment programs, and it's not dispensed in pharmacies, in vendor pharmacies and in community pharmacies. And, you know, I think we hear about, you know, this person has cancer. Can't you just prescribe their methadone? I mean, that does come up a lot. There are patients who are started on methadone who maybe have a history of opioid use disorder, who then get discharged maybe to a nursing facility or to home with a follow-up with a palliative care provider where they were started on the methadone because they have pain, but they also have opioid use disorder. But their prognosis is, maybe many years, or they have an opioid use disorder that needs to be addressed, from an addiction perspective. But then they're kind of in this limbo of, who's the hot potato, who's taking over this methadone prescribing. And I'm of the mind that for patients who are at the end of life, that palliative care becomes primary care. It becomes addiction care. It becomes everything. We have to have the capacity to assume all management for our patients. For example, when patients are homebound, They're physically unable to participate in a methadone program. They're nearing the end of life. It makes sense in that situation to assume methadone prescribing for pain and opioid use disorder. And so that's the scenario where I'm, really thinking about that. I think assuming methadone prescribing as a palliative care provider for patients with longer prognosis, I think that's a more fraught scenario. First from a legal standpoint, really, being that methadone can only be dispensed in OTPs, and a lot of patients do actually, benefit from the structure of a methadone program, where we, see good retention and care. Some patients really identify with, being, in a methadone program. They have a counselor that they maybe have been seeing for decades, and there actually is a, piece of identification with that. And, there have also been situations I found myself in where I'm prescribing opioids for someone on methadone maintenance. And because it's sometimes easier and more convenient to get medication from a pharmacy, patients start to kind of lapse in their care at the OTP. And this can become chaotic and sort of destabilizing for them. Um, and sometimes patients who have a lot going on psychosocially, their cancer care or other chronic disease care can fall to the wayside in favor of focusing more on palliative symptom management, right? It's like a hierarchy of needs. I need to feel okay as like step number one. So, I really try to keep patients engaging in the multiple dimensions of their health and to really keep the interdisciplinary team involved as much as possible, to address the various needs that can come up for patients.
Yeah, and that sounds like you're really advocating for comprehensive, holistic care, recognizing that there is real value from the addiction treatment team at the opioid treatment program and not devaluing that it's not just about a medication alone, that there's a lot of wraparound services. So, similarly to trying to, in palliative care, support someone so they can engage in cancer care, palliative care supporting someone maintaining engagement with their addiction treatment. Justin, what's been your experience?
Yeah, no, I think those are all good points, and I think just a couple things I wanted to highlight. I've been amazed by how many patients really have been coached so well about the importance of how they take their methadone, that when we talk about we've got clearance from our addiction colleagues to divide the dose up. How many folks don't want to divide the dose up? They have just been they have been so well coached, and this has helped them in so many different ways. And we really go through the reasons of why this might help them. We've gotten the approval to do so, and they just don't want to divide up more than once a day dosing. And like Lauren said, like a lot of times in cancer management, we'll do it 3 times a day. But the best we can do is get our patients to cut it in half. There are a couple things that I want to be mindful of too. Is like when we traditionally think of how we utilize methadone in palliative care, right? We're talking doses of 10, 20, maybe 30 milligrams a day until we are maybe treating some niche patients really close to end of life in hospice. Like we're talking low dose, slower doses, right? And very different than what we're talking about here in the treatment of OUDs. So that also comes up. Like why can't you just take over? Well, there is it's a different skill set too. Honestly, it's a very different skill set. The other thing that come up a few times just to bring up are folks who are on clinical trials. I don't know if you've come across this.
I have come across that. Thanks
Yes.
for bringing that
Yeah.
up. That's so true.
Yeah. In clinical trials, many times they have, they have very strict protocols, but one I've come across more often than not is they cannot be on medications that prolong the QT interval.
Yeah.
And what do you do when you get that request? I want to be on this clinical trial. This is, my proverbial like last chance at something, but I can't be on this clinical trial if I'm on my methadone. And that could be a whole separate podcast, a whole separate conversation. But I
Right.
think some of these things you have to be mindful of. And I mean, really, it goes back to those collaborations and conversations. And I mean, that's obviously a very individualized approach, but taking time. But I think methadone is such a wonderfully beautiful medication that has a lot of great uses, but some of these intricacies, I think, just add challenges to how we think about caring for our patients.
Yeah, and so speaking more that it's not as simplistic just to say, hey, there are barriers, so prescribe it, that there's like real medical
Correct.
considerations like addiction treatment, like the difference in doses for pain and cancer pain, just like you mentioned for buprenorphine, right? There's a much higher doses for someone with opioid use disorder, and that safety profile is just so different. That's why we can prescribe buprenorphine, but we dispense methadone and by somebody who's skilled. And then that pearl, yeah, I've encountered that recently as well with those clinical trials and these newer cancer therapies that the methadone being an exclusion for QTC prolongation concern.
Yeah, sure. That's the thing too, and I apologize for not mentioning this earlier, is sometimes we'll do a little more monitoring of their labs because these folks get ill, they don't feel well, right? They're not eating and drinking as well. And so just really looking for a lot of electrolyte levels. Again, just really thinking about the safety of the patient, taking a little more those things into mind, making sure that potassium and magnesium are all falling in with the normal range. Sometimes we'll do a little extra monitoring for our patients there to help them feel better from a safety perspective as well.
Yeah, thanks for naming that too, because that does, it seems like the conversation I usually hear is, if these are just barriers, you just prescribe, don't they have cancer pain? And methadone's great, but we forget there's particular to it, QTC prolongation and in cancer treatment, you have a lot of nausea, vomiting, diarrhea, electrolyte abnormalities. So just respecting the pharmacology of methadone. And so I just wanted to shift, though. So we talked a lot about opioid complexities, methadone, buprenorphine, and everything that makes cancer treatment unique for patients. But Lauren mentioned earlier about people are living longer, and she talked about talking and setting the stage about tapering, but being very individualized. So when we're moving away from cancer treatment, how does survivorship management change?
Yeah, no, that's a fair question. I'll start, and then I'd love to hear how you two feel about this as well. But really, this has been a big change in my career in palliative care, that this cancer survivorship pool is growing. Thankfully, it's growing, and I kind of lump into those folks who I don't have a better term, but I call it chronic cancer. These folks are going to live with cancer for 5 or 10 years, and so they're in this period of disease stabilization from their treatment. And what this now opens up are opportunities to think about chronic pain management. And again, I using that term, we used to again differentiate chronic non-malignant pain and chronic malignant pain management, but I think we group those together now and recognize that when you have patients who either have no evidence of disease or are stabilized from a cancer treatment perspective, we have more opportunities to think about other modalities for their pain. If we can de-escalate opioids, great. Again, we have to separate what are we treating, pain versus other use disorders, right? Being mindful of that. But in addition to that, are non-opioids now an opportunity? Can we use things like acetaminophen and NSAIDs? Keeping in mind other comorbid conditions still, as we always do. But these now might be opportunities when we're not so worried about them having risk for infections or bleeds or those kind of things from their cancer treatments. Also recognizing things that are so valuable non-pharmacologically, PT, OT, pain psychology. Though we recognize the value of those things, it's so hard to implement those again in the midst of cancer treatment. They're already so overwhelmed with their treatments and their treatment appointments. These now become an opportunity for us to reconsider. And we recognize chronic pain is chronic pain is chronic pain, that non-pharmacological strategies are really important in our approach. So these become opportunities to support our patients in the treatment of their pain. Interventional approaches before as well are also things that can be considered. So recognizing that we look to de-escalate opioids as appropriate for pain, and we got to again be mindful. Are those short-acting opioids, which are a little easier to do? And in the context of things like buprenorphine and methadone, that's a separate conversation. But folding in other meds and more importantly, non-pharmacological. But Lauren and Katrina, again, I'd like to hear kind of some things you guys think about as well there.
Yeah, I think about patients, when they're moving through cancer, that they suffer a lot of insults to the body. Um, And that looks different, of course, for each individual patient, but very often we're seeing more debility, um, sarcopenia, loss of muscle mass, malnourishment. Many patients may have been exposed to drugs that cause neuropathy. Many have had major surgery or radiation therapy that can leave them with scarring and chronic pain. So it's really common to see chronic pain among cancer survivors. I think it's like nearly a third of cancer survivors have chronic pain, and like close to 20% of them have high impact chronic pain that affects their function, which is basically double the general population. So all of these cancer related insults, can beget even more pain, and so opioid dependence, can persist much longer than expected. Tapers of opioids can be more extended. And thinking about the disease trajectory, there's a risk of cancer recurrence. There's the potential for new sites of pain. This particularly comes up quite a bit in head and neck cancer, where it can be multiple months after completing intensive chemoradiation treatment before we know if disease is in remission. So the trajectory is not always linear, and pain and function and prognosis, all of these things are sort of shifting all of the time. And so, I think it's key, as it is with many conditions, to take a really patient-centered, individualized approach.
I love how you say that because the cancer trajectory, where they are and what we expect is so paramount. And again, if I'm going to tell on myself, my young self, I didn't think about those sort of things. They had cancer. Again, we did a nice job of treating that, but we have really revolutionized the way we think about how we treat patients in palliative care. And that trajectory is so important. Again, it goes with that collaboration. And to your point, Lauren, we got to recognize that it's not linear for everybody. And when we do have periods of stabilization, we do think about de-escalating because we want to decrease their tolerance for if they do have a reoccurrence, right? So we tell patients this isn't just because we want you off opioids that, and we hope you stay stable within your cancer or your main evidence disease, but we're also mindful these things do recur, and we want to, as much as we safely can, while keeping you functional, drive down your tolerance so you are able to have functional opioids moving forward if need be.
That's such a change from before, right? I remember telling on myself how old I am, but at the turn of this century, the thought always was, oh, there is no ceiling, there is no ceiling, and you just add more. But now really respecting that tolerance and that ability to respond to the opioids. So, but yeah, thanks for expanding on that conversation of it's not just okay, cancer treatment's done, and it's similar to the ER trauma scenario. They had surgery, you went up on the opioids, and 3 days later, as you go back down, as soon as you're done with chemo, we start going down. It's no, you've really got to look at all of the neuropathies, the cachexia or sarcopenia, where the residual pains, all of those things together. You don't just say cancer pain and then, pain after cancer treatment. And you take all of that, and yes, simplistically, we can decrease medications, but there's so much more to be done, even more so than after a car injury or something like that, within talking about cancer. I want to close out, though. You guys mentioned it several times about collaboration. And so for those listening, and just say, it sounds really great, you're picking up the phone, but how do I actually apply that to my practice? So what would you guys recommend for our listeners?
I can start with what we do here at Ohio State, and it takes time. I mean, I can't. I wish I had an easier solution, but it takes time. And we have, our proprietary system is Epic, and so we have internal chat. And what we very frequently do is set up an internal chat as we're beginning to see a patient. Hey, we're seeing this patient. We recognize, and oftentimes they're referring them to us anyway. So we have that kind of that needs an initial dialogue. We see they're starting cancer treatment. here's what we understand. Could you please help us fill in some of the gaps about what their cancer treatment is going to look like? What can we expect and understand? So that way we can also help the patient understand, um, from that perspective. And then we'll then let that team know what our approach is going to be and how we anticipate supporting and managing the patient through that. But it is oftentimes starts off with just opening that line of communication through an internal chat. They may or may not respond, and that's okay, but at least we've got to start it. If we do have periods where the symptoms are worse than anticipated or things changed, then that dialogue has at least been initiated in that way.
Yeah, I can add to that as well. From my perspective, the ability to phone a friend is crucial. Having mentorship relationships, and even more importantly, having a forum, like a larger forum for discussion about tough cases, has been really helpful. I've become very involved in running a monthly interprofessional case conference within my own institution called GPAP, Geriatrics Palliative Addiction and Pain Collaborative. Katrina, a plug for MAPIT, a national interprofessional case conference. And I think it's these kinds of conferences where clinicians, trainees, all members of the care team can come together and get support from specialists on how to manage care in these really challenging scenarios. And it's where we can deliver education in the fundamentals of addiction and managing the pain substance use disorder overlap in a really applied setting. So I think it's important to get institutional support to do these things, to support these types of conferences. And additionally, clinical service integration, wherever that's possible, is so helpful. So having things like supportive oncology embedded in the cancer center, or having inpatient addiction consult services who can work closely with medicine teams, surgical teams, having it embedded addiction care in the ambulatory setting, like within primary care or in behavioral health settings, and cancer centers. So that's where I think the real magic happens, where clinicians are working right alongside each other and can collaborate on these things.
So I guess we're closing with, work with the other people who are working with the patient, right? Get a clear picture of what to expect. But when no one's the expert in the room, kind of create forums and participate in forums where you have some peer mentorship, some experts in the room to guide you when the patient has so many needs. And that there are many reasons why cancer pain is unique in this. The prolonged exposure to opioids and the longer recovery time, and then also when it comes to patients with addiction, particularly for opioid use disorder, really understanding the difference of treatment for opioid use disorder, making sure that we've got the right medication and enough of it on board, but still treating cancer pain as we would anyone else. So that was my takeaways that I got from you guys. So thank you so much for joining us in this conversation. Lauren Kelly, Justin Colgren, I always appreciate talking with you and your expertise. And so, just for our listeners, remember that first, cancer-related pain is common and will require opioid therapy a lot of the times, but thoughtful conversations about safety expectations, reasons for being prescribed that, and treatment goals can reduce the fear and stigma for patients and the prescribers. Second, patients with cancer and substance use disorders deserve effective pain treatment, and medications like buprenorphine and methadone do still play an important role in safely managing a patient with pain and opioid use disorder. And lastly, caring for patients with cancer pain is a team effort. So collaboration with all the specialists, oncology, addiction medicine, palliative care, primary care, et cetera, ensures that patients receive comprehensive and compassionate care with the right approach at the right time. And to our listeners, thank you for spending time with us today. To find some ongoing education and to connect with experts to help you thinking through your complex patients, we would recommend CAPC, Center to Advance Palliative Care, with some modules on pain and substance use disorder, which Lauren helped to create, as well as PCSSnow.org, which Justin has been involved with as well. If you found this episode helpful, we encourage you to share it with a colleague or someone in your network.
That was Dr. Justin Colgren and Dr. Lauren Kelly in conversation with Dr. Katrina Nichols on Frontiers in Substance Use Care, Emerging Topics and Evidence. Thank you to Dr. Nichols, Dr. Colgren, and Dr. Kelly for sharing your expertise and offering practical guidance on this complex area of care. And thank you for listening. This MRSA podcast series is created in partnership with the Providers Clinical Support System, Medications for Opioid Use Disorder. To learn more about PCSS, MOUD, and MRSA, please visit pcssnow.org and immersa.org. Technical production is provided by Podpaste. Funding for this initiative was made possible in part by grant number 1H79T1086770 from SAMHSA. The views expressed in this podcast do not necessarily reflect the official policies of the Department of Health and Human Services, nor does mention of trade names or organizations imply endorsement by the U.S. government. Disclaimer: the information, opinions, and recommendations presented in this podcast are for general informational purposes only and should not be considered medical advice. This podcast is not intending to replace professional medical consultation, diagnosis, or treatment. Any reliance on the information provided in this podcast is at your own discretion. While every effort is made to present accurate and up-to-date information, MRSA makes no warranty, guarantee, or representation regarding the accuracy or sufficiency of the content featured. The views expressed by guests are their own and do not necessarily reflect the views of MRSA. Their appearance on this podcast does not imply an endorsement by MRSA of them, their viewpoints, or any entity they represent. Unless explicitly stated otherwise, MRSA does not endorse, approve, recommend, or certify any information, product, process, service, or organization mentioned in this podcast. Information from this podcast should not be referenced in any way that implies such approval or endorsement. MRSA expressly disclaims all liability for any direct, indirect, incidental, or other damages resulting from an individual's use of, reference to, reliance on, or inability to use this podcast or the information presented in it.